Well, welcome to this podcast discussion. It's part of our Perspectives in Inflammation series. And our objective here is to tell you a little bit about one of the superstars of global rheumatology, and also someone I'm very privileged to call a dear friend, Professor Chris Buckley. What we want to do today is to talk a little bit about the incredible success enjoyed by Chris just very recently in the award of the Carol Nachman Prize. Now, some of you may also be aware this is the 100th podcast brought to you by the Cytokine Signaling Forum. And it is something of a coincidence that we have the chance to honor you, Chris, to learn a bit from you, and also to celebrate the fact that 100 podcasts have now come to fruition, talking about the incredible power of pathogenesis understanding and promoting the treatment of people with rheumatic and musculoskeletal diseases. By way of introduction, my name is Ian McInnis. I'm the Muirhead Professor of Medicine at the University of Glasgow. And it is an absolute pleasure, Chris, to have you with us. You're the Kennedy Professor of Translational Rheumatology at the Universities of Birmingham and Oxford. One university isn't big enough for you. You need at least two, which is quite extraordinary. And as I've mentioned already, we learned this week that you've been awarded the prestigious Carol Nachman Prize in Rheumatology. You follow great names in the discipline there, and it is the foremost international award in our discipline. You must be really pleased, Chris.
Of course, Ian, and I'm even more pleased to be following you, since you were awarded it last year with Ellen Gravelese. And of course, these gongs are good fun, but actually what it's kind of rewarding is the team behind it and this sort of approach. And I'm delighted, thank you very much to the Cytokine Signaling Forum for asking me to do this 100th podcast. It's an exciting time to be in rheumatology. Cinderella has come to the ball, you know. The cytokines have been an important proof of principle that we can inhibit those and affect people's lives.
I couldn't agree more. I personally think rheumatology is just at the very front edge of molecular medicine applied to curative, eventually, therapeutics, Chris. I believe we've been at the front of the wave for the last decade, and now never more than before with the modern molecular science that you and some of your colleagues are applying. And you know, we have the pleasure of working together. So you've persuaded me. I've even learned to spell the word fibroblast, Chris. I suspect we're going to hear a bit more about that just in the next few minutes. But the idea of team science, incredible molecular biology, the digital and analytical science that supports that, and the ability for us as clinicians to now really dream big for our patients. I couldn't agree more. It's an incredible time to be a rheumatologist. Chris, tell me a little bit about just this prize is a recognition of many, many years of diligent science and I guess a bit of perseverance. Do you want to take me right back to the beginning? What provoked your interest in this area of stromal biology, which is the area for which you've been most properly recognized?
Yeah, so I mean, I've been a bit of a kind of strange hybrid. I started my scientific career with a biochemistry degree, actually in Oxford. And then after that, I did medicine at the Royal Free in London. So I couldn't decide if I was a scientist or a clinician. And the truth is I'm a bit of both. I guess if you were to really push me in, you know, and say you can only do science or you can only do clinical, I would probably end up being more of a scientist than I am a clinician. But that changes over the course of your career. So I started really interested in the biochemical processes, actually of metabolism. I was very interested in that. And then when I was doing medicine, this was 1985 to 1990, the graduate entry medicine was not popular. And so the only place that would take me was the Royal Free, which of course had a tradition of doing odd things. And it was one of the first medical schools to admit women. So it was a terrific experience. And then after that, I went back to Oxford, having done some of my medical training in London, and did a PhD actually at the Institute of Molecular Medicine, as it was then, with a very big mentor of mine, David Simmons. I worked on cell adhesion molecules, how leukocytes adhere to endothelium. And that's when I first got interested in fibroblasts, because around that time, the gurus of fibroblasts in rheumatology, Nathan Zweifler, Stefan Gay, were, and Gary Firestein, of course, were really pushing these cells as being important, not just, I guess at that stage, to destroy joints and destructive phenotype, but I got interested in whether they might have an immune phenotype, particularly in regulating how cells behave within tissues. And that's when I kind of started off on this. And moving to Birmingham in 1996, gosh, it seems like only yesterday, I followed in footsteps of people who work on thymus, Eric Jenkinson, John Owen, Graham Anderson, and so was very much led by their understanding of stroma and the role of the fibroblasts and stromal cells in educating T cells in the lymph node. Ian McClellan in the lymph nodes, of course, germinal centers. So my microenvironment in Birmingham was very much driven by that. So that's the background really to the interest in stroma. And I think 3 revolutions have occurred that allowed us to really formally kind of prove that these cells are critical. One was single cell sequencing that allowed us to get at them. I guess also the ability to get tissue out of humans in a minimally invasive way, ultrasound guided biopsy. And then kind of the final bit was the proof that anti-cytokine therapy did what it said on the can. So if you had an anti-TNF, really apart from some FC receptors, it'll bind TNF. So those 3 things coming together led to the ability to then formally implicate these cells in disease.
Often heard you introduce lectures, Chris. I'm the guy that studies the forgotten cell. Poor me, pity me, for I am a fibroblast investigator, and nobody cared until now. And do you think it's really true now, or do you not think the stromal cell is sitting front stage and center in pathogenesis?
Yeah, I think now that's the case. Probably partly because inflammation has been dominated a little bit at the beginning by immunologists, and stromal immunology really came of age, I guess, 20 years ago when those discussions were beginning, and people realizing that, you've heard me say this before, that, T cells and B cells are the equivalent of Oxford and Cambridge educated in the sense of, and I ought to mention Glasgow and Edinburgh, of course, but Harvard and Yale. So they're highly educated cells. They've got a terrific ability to have memory, and boy, do we need them now with COVID. But the stromal cells are, went to the polytechnics and learned how to build structures. But we realize you need both. You can't have one without t'other. And I guess in the inflammatory field, fibroblasts for years have been known to be critical. They make many things that drive responses. So yeah, of course, it's the evidence, I think, that would convict the fibroblast in a court of law as having a role in driving inflammation and producing cytokines. After all, in the synovium, the cell that produces the most amount of IL-6 is the fibroblast. But it's a bit of a tease to say that it's the poor fibroblast. Of course, it's not. I mean, it's the whole microenvironment together.
I just want to pick up that last remark. I couldn't agree more. We're both rugby fans, Chris, and depending on what position you played when you were a young lad, that'll be the best position in the field. I was a wing forward, so that's obviously the best position in the field. The team couldn't function without a wing forward. But I think the truth is that a team is just that. It's a team. And I think that's one of the fundamental changes in the way in which we're starting to think about rheumatoid arthritis pathogenesis, and actually about the pathogenesis of a whole range of immune-mediated inflammatory diseases. We're thinking increasingly in a systematic way. And, I think the single cell sequencing revolution has made that an imperative, because in fact, when we start to look at individual cells present in a joint, progressively it becomes harder and harder to categorize them, doesn't it? And then to try and understand how many relationships are going on in even a single synovial biopsy, it's certainly beyond the capability of a single human mind. And you've therefore, I think, done a brilliant job in bringing the informatics skills and the systems biology skills necessary to really capitalize on those advances that you were describing a few moments ago. Do you want to elaborate a bit on that?
Yeah, I mean, you know, it's a huge privilege, of course, to have you interview me, because, of course, we know each other very well, as you say, not only enormous friends, but actually colleagues working together in big consortia like the Rheumatoid Arthritis Centre of Excellence, funded by Versus Arthritis. You know, we've often joked together, you know, art is me, science is we, the collaboration of Newcastle, Birmingham, and now Oxford. I guess what it allows you to do is answer big questions. And I think as rheumatologists, we think big. You know, the COVID crisis has shown us people are dying of inflammatory disease where the virus has hit and run. And to answer very big questions like how cells interact, we have to have teams of people. Like my colleague in Oxford, Mark Cole, suggests, the problem with life sciences is we haven't worked together as teams. If you're an engineer, you have to work together as a team to get something done. To put an airplane in the sky, you've got to have all the different components, otherwise it crashes. And we've had a reward system that rewarded the elite athlete. And so I think rather than wanting to be the decathlete who gets all the glory, I would rather have the 10 best people in the world, so that, you know, the best sprinter, the best javelin thrower, the best high jumper, because if you had all those 10 working together, they'd thrash the elite athlete decathlon who got all the glory. So, but it takes a lot of trust and time, you know, and the current models are tricky because, you know, one university wants to be the best. And so you've got to, as you work cross-discipline, cross-institute, you're really challenging the status quo that actually, you know, I win when you win. The model has always been I win because you lose. And we've got to challenge that. And I know, you know, you passionately believe in that. And it's great, not only that, but John Isaac's our very good friend. And so when we come together, you know, your expertise in cytokines and in the acquired immune response, John's expertise in doing experimental medicine and dendritic cells, our expertise in fibroblasts, you know, that combo really has revolutionized the way we can answer these big questions.
Yeah, you used a word just a moment ago, Chris, that has real resonance with me. I think the word you used was trust. And you also mentioned RACE, the RA Centre of Excellence, which is now a Centre of Excellence actually for inflammatory arthritis, generously funded by Versus Arthritis. But sometimes we almost feel a bit of a fraud because it's just actually a group of curious friends who love working together, who love thinking of the toughest questions and then just love getting on with answering them. And as you mentioned, just as I think of this discussion coming together, you mentioned the incredible advances that are now possible in the power of molecular medicine. But trust goes beyond colleagues working together, Chris. And I wonder if I can just tease you into thinking also a little bit about the central role that patients have. And it's not an artificial approach to say, oh, we better have a patient representative. I mean, one of the things that I think has driven your work over the years, as it has my own and that of many others, is a fundamental appreciation of, first of all, what dreadful diseases the rheumatic and musculoskeletal conditions are. And secondly, how extraordinary are the insights we gain when we talk to people with this disease. Do you want to maybe share a few thoughts in that area? Because that and, you know, the contribution of biopsies and samples and all that goes with that has been a core part of your work.
Yeah, you know, nothing about us without us, the kind of motto, of course, Euler and Pare. And I think, if I'm honest, at the beginning, you kind of think, oh, well, yes, it'd be nice to have their insights. But actually, it's more than that, not just their insights, their involvement and ability to change the way we think. Because, you know, my good friend, Andrew Filer, who really started the ultrasound-guided biopsies, you know, he was very passionate about the fact that patients would have to have these biopsies done to them. And there was a lot of sort of patriarchal views, we know best as doctors, oh, they won't possibly want this. And then when you speak to people and explain to them, actually, they become the best advocates. And And in order to do human biology, we're not vets, and we don't want to cure mouse arthritis. We want to cure human disease. And so getting folks on board to help us understand what we think is possible and what's not. And I can only speak for the RACE consortium has been brilliant at getting people together and asking views about what do you think about this. And people often ask the most simple of questions, which is profoundly true. How many people are you going to save if you do this? How many people are you going to treat? Not what's all the interesting science, but how's it going to impact? And I think those approaches make the patient story very relevant, and particularly when you're explaining about multiple biopsies. When we explain, as we have done together and in groups, that biology is all about how things change over time, that a single snapshot, if I take a picture of the two of us now, a single snapshot, that won't tell very much, but if I showed the video, we'd understand it. And so to encourage people to have 2 or 3 biopsies, or even, goodness, a biopsy in 2 different sites, after all, the joints are, they're all over the place. That's a big challenge, but our patients encourage us to do that. And that, I think, has been a huge advance. As I said, the 3 things: single cell, the ability to get tissue, and then the ability to put drugs in to measure that delta, that change.
And a very concrete example of that, Chris, you'll recall very well that when we originally imagined our collaborative work many years ago now, we were focused at that stage on early disease. Let's get in really early, and rightly so, because early or even pre-disease is an opportunity for prevention. But when we came to renewing our centre grant together, it was patients who said, hang on a minute, what about us? What about the people with established disease? And what could and should you be learning from us and doing to help us? And of course, from that, Chris, came some of the real momentum in your stromal work. It gave real momentum to our focus on remission, trying to understand, well, if someone's in remission, why is that? Why do they stay there? And that, as you know, has brought shared publications and real insight into why disease isn't there as much as why it is there. And so the patients took us to establish disease. They took us to remission. It's an unwise clinician scientist that doesn't listen to the sagacity of their patients, I must say. And you're an example of someone who's listened, I think, better than almost anyone. Chris, I want to take you on now. I want to maybe now tap your brain on the kind of structures that allow great science to take place. We're in a post-COVID or peri-COVID really era now. We're being told that we're going to have to innovate to get out of a potentially quite severe economic recession. We're going to use human ingenuity to get there. And of course, we want rheumatic musculoskeletal diseases to be at the very forefront of that innovation and ingenuity. But that requires a model, doesn't it? It requires a place for science and clinical science especially to be done. And you've really, you've led the way once again here in the creation of the Arthritis Therapy Acceleration Program, ATAP, to help those of us of a Glaswegian tongue who struggle with long titles. Tell me a bit about ATAP. Where did that come from? What is it?
So I guess once I was interested in stromal cells, I began to wonder why patients with arthritis get certain joints affected. You know as well as I do, when you go into the clinic and somebody comes and they've got puffy joints, you're interested in looking at the pattern. Clinicians are good at a few things, but what they're really good at is recognizing patterns and making that pattern link to something they've seen before. So the interest in why the knuckles, both knuckles, and then why the skin, why the eyes, why the gut. So these well-known things like, patients with inflammatory bowel disease sometimes have eye problems and sometimes have skin problems, and the spondyloarthropathy, psoriatic arthritis, things that you're very interested in. Patients don't make these connections, but we're taught to do that, pass our exams by that. So I was always intrigued. And of course, fibroblast is a cell that's present in a number of places. So I began to wonder, what would a fibroblast in the joint look like compared to fibroblasts in the skin or in the eye or these places where we get this comorbidity. And it struck me that actually the only way you could do that is to work across disciplines. And the problem with medicine is it's siloed into these ologies, rheumatology, gastroenterology, dermatology, but biology doesn't give a fig for that kind of classification. It's a human construct. It cares about the cells. And so I realized that to do that, you needed to have cross-discipline approaches. And we all talk about multidisciplinary and so on, but actually we all revert back to our silo. And so it was in that attempt to how can you get involvement with gastroenterologists, dermatologists, ophthalmologists, that in Birmingham we kind of started to begin that, and our institute tries to do that, cross-disease specialties. But I realized that that just wasn't going to be enough, and we would have to have cross-institution because there were strengths that one institution had that not another. So partly, with serendipity, and I remember getting on the phone call for you to just come off a plane back from the States saying, Fiona Powery, my great colleague, of course, who's now my boss in Oxford, had just contacted me. Chris, what do you think about an opportunity to do something like this? The Kennedy trustees, they, of course, made their money from the anti-TNF and methotrexate combination, have suggested that we should think about a cross-university, cross-discipline, and I jumped at it, of course. And you encouraged me because you never know with these things. And that's 3 years ago now. So the Arthritis Therapy Acceleration Program is really the first cross-disease, cross-institute kind of collaboration to try and get at what are the commonalities and what are the differences in cell types. And I think timing is everything. And so that's coincided with the advent of the Human Cell Atlas. A very simple question, how many individual cell types make up an organ in a synovium? And that question is hugely important, and yet in the 21st century we can't answer. And that becomes relevant for the cytokine signaling forum, because we know that TNF is important, we know that IL-6, but we don't know which cells are making those in different sites in the body. So that was the kind of background, and the Kennedy trustees were good enough to fund it, and so that's the beginning of it. And it's if it's going to have credibility, we should be able to move forward to accelerate studies in patients early on, and that innovation is going to be critical, because how are we going to get in post-COVID these experimental medicine studies? We have to crash down the numbers of patients required. So I think the innovation will have to be less patients in trials. We can't afford to have 200 patients. I think we won't be able to quite have placebo arms like we've had in the past, because who would want to go into placebo arm when you've got a very good therapy? For example, in COVID now, who's going to want to not have dexamethasone? So I think the days of, particularly for IBD, less so for arthritis, of placebo-controlled trials going to have to go. We'll have to have against best care. And we'll need smaller numbers of patients. And I think utilizing biopsies and looking at tissue will reduce the number of patients we need. And we have to engage our patients to say, do you want to do this? And then the regulators. So there's lots of, these are wicked problems in the sense it's like whack-a-mole, you solve this problem and then another one pops up here. But to do that, you need a consortium of people, not just one organization. So that's been the kind of philosophy behind it.
Well, of course, Chris, one of the signs of a really good friend is, because I have to say I remember that conversation very well, and it's being able to say, go for it, it's fantastic, when one is actually insanely jealous. And I really have been pretty jealous of the ATAP program. Of course, the joy of the Inflammatory Arthritis Centre that we share is that, in fact, ATAP has become part of that. And one of the great consequences, in fact, was the Kennedy and Oxford joining the centre collaboration, to enormous mutual benefit, I have to say. But just, in a couple of words, what do you think are the key findings that have been a result of the ATAP initiative?
I think the critical things are the tissue is important, understanding the cellular ecosystem of a tissue. and how that relates to the infiltrating cells and inflammation. So
and it led you to this concept of subsets of fibroblasts, and the way that there are subsets of T cells, subsets of B cells, maybe even of macrophages, although you'd have to put a gun against my head before I was prepared to commit to that quite yet. But that for me is one of the most striking things you've contributed to our literature.
Yeah, and I think ATAP kind of, having a question without the technology to answer it is very frustrating and sometimes futile. You need the technology to answer the question, but you need also the question to apply the technology to. And I think that's where having, none of us have 360 vision, and therefore the challenges of working together mean that you're pushing at those boundaries. People bring different things in. But the understanding of the cellular basis of disease, this cytokine is made by this cell, and the receptor for that is here. And the work we've just done together, a huge success for RACE, how does the macrophage in the synovium relate to the fibroblasts in the synovium, really is, I think, and why that's important, Ian, because people want to know, mechanisms always matter. People want to know the mechanism by which something is happening. If we're going to drug something, take a drug, we have to know the target. You can't design a drug unless you know the target. And equally, I don't think you can really understand biology unless you understand the cell. The cell is the equivalent of the element in the periodic table, how those cells interact. And what I think we're beginning to see is that the fibroblasts and macrophage in health are very important in that kind of lining layer. And of course, subsets, what does that mean? But again, in this analogy of the periodic table, subsets to me are like elements in a family in the periodic table. You might have, lithium, sodium, and so on. You might have chloride and bromide. They're similar, so you can call them that family member. But how sodium goes with chloride to make salt is different, but similar to how lithium goes with chloride to make a different salt. And I don't think we could have done that had we not have had multi-university, in other words, cross-institute, cross-discipline, because I've learned so much about macrophages from you and of course, our good friend and colleague Mariola, who's really been persistent at doing that, and equally dendritic cells and equally lymphocytes. And of course, the truth is in the end, we have to put that together. That's going to be the real challenge, all this big data, how we put it together and show functional consequences for that.
It's interesting you mentioned Mariola Kroska-Stolarska and others like Carl Goodyear and colleagues who have helped us in this journey, and in your own place, Adam Croft and others. And these are people whom you and I have mentored from career development fellowships now into senior established tenured posts. And in truth, they're leading us rather than the other way around. It's one of the great joys of academic life is mentorship and seeing the success of those that we had the privilege of training. You're one of the great mentors in our discipline, Chris. You teach us all. Do you want to maybe think out loud about just how important that is for our discipline at the moment?
I think for the clinician scientist, that kind of dying breed, it's dying not because people don't want to do it, but you end up being caught in the middle. You're neither a good clinician nor a good scientist. And I think the only way to solve that is to have teams of people that can kind of protect each other. And so there is a magical kind of size, if you like. It's like kind of Goldilocks, not too hot, not too cold, just right. It varies from discipline to discipline. But unless, you think about the mentors you've had, and I talked about David Simmons and others, unless you see that it can be done, it's very hard to be the pathfinder. So, and I think, that's one of the most fantastic things is to be a proper mentor. And as you just said, friendship is about having a good degree of jealousy, because that's important. That pushes us on. I call something the jealousy index. And there's a paper just published in Nature this week, actually this is the paper I'm most jealous of, basically comparing structural cells from 12 different organs, endothelium, epithelium, and fibroblasts, proving once and for all that these cells are the immune regulators because they affect how cells coming in. A fantastic paper from a group in Vienna. And I always laugh and tell my folks, if the jealousy index is over 100, that's a super paper. But you need that kind of thing. But what you don't need to be jealous of is the people who are coming up behind you. You need to be jealous of your colleagues, and that's good because it's healthy. You and I, but you can't be jealous of the folks coming up behind you. And if you're any good as a mentor, they should be better than you. And that's tough sometimes, to put the ego at the door. But when you do that and you look at the people who've mentored people through, look at the great rheumatologists before, I don't want to call them all out because I'll get cross if I don't mention them, but who mentored us. That's the legacy we have to leave. To be jealous with each other because we're colleagues together, but not to be jealous of the ones coming up and who are actually better than us.
So your daddy bear, mummy bear, baby bear analogy makes me think of family, Chris. Your career has been underpinned by enormous support at home. I know that. How important is that work-life balance been to you over the years in being a sustained, productive, international academic, but also a thoroughly decent human being?
Oh, now he's flattering me. But you're right. I love that quote in Harry Potter. Dumbledore is speaking to him, and Harry Potter's, kind of really anxious about the future. And Dumbledore says to Harry, it's not our abilities that shape our future, but the choices we make. And, I often think of a kind of, I'm a very big Trinitarian. I like things in threes. Your family, home, your work, and you. And very occasionally you hit the sweet spot of all three. It is challenging because you and I know that we're odd. I mean, to do what we do is odd. And in fact, we're not normal, if we're really honest. And to have family to put up with us, your dear wife as well. In the COVID era, we've not been able to travel, which is great because we can be at home. But we are obsessed with something that is actually more than just a job. It becomes a hobby, and we have to watch it, that it doesn't become obsessional. So I am very fortunate to have 3 boys and a wonderful wife who keeps me grounded and says, you are getting to the point that you're objectionable, you're obnoxious, it's time for a holiday. And put away that phone, you're not allowed to look at it. And as your wife has done, 10 o'clock curfew, you can't look at it. Because it's tempting to think that, you can answer all the problems, solve everything. But the nice thing is that we don't have to, and the world will carry on regardless. But you're right, family are so critical, and but to keep you grounded,
Yeah, I think that's a lovely message, particularly to some of the younger physicians and potentially clinician scientists who are listening to this podcast. Just before we close, Chris, a couple of thoughts perhaps on where we're going as a field in rheumatology. What do you think the big hits are going to be in the next 4 or 5 years?
It's a wise man or woman who predicts the future. If you want to make God laugh, tell him your plans. But I think we're in for some exciting times. As a specialty, you think back to when, Maxim Dugudas always had that thought experiment. Think of an outpatient in the 1960s, then in the 70s, and then biologics come. Suddenly everything has changed. Methotrexate, a huge game changer. Mike Weinblatt, we're really underappreciated for the amount of effort going in. That was a big game changer. A bit like dexamethasone, cheap as chips, going to change, at least for the very sick patients now on ITU. But I think we're going to move from biologics now to being able to target the cells that those cytokines are making, and understanding the ecosystems. Combination therapy may well come back now we understand it a little bit better. I think for us as rheumatologists, as awful as COVID has been, COVID is kind of like vasculitis. It's the whole area of thromboinflammation. I don't know quite where rheumatology will go, but I do think we will end up being important physicians in that area of inflammation biology. And whether it takes us into fields of non-infectious inflammatory diseases, infectious inflammatory diseases, our patients have taught us a lot about inflammation, but I think now we owe back to use that inflammation to break down these silos. You remember when we learn medicine, we talk about the surgical sieve. Is it congenital or is it acquired? Is it neoplastic? You know, is it infective? Is it metabolic? I think medicine will boil down to 5 kinds of sort of processes. The inflammatory process, of which I think rheumatologists should be a big component. Degenerative processes like neurological diseases, metabolic, infective, neoplastic. And those processes really are what drive. So I would love to see a future where we didn't call ourselves rheumatologists, we're inflammation doctors. And we embrace that diversity and stop trying to just look at the joints. And if we do that, I think that would be an exciting thing with all the new therapies that we have.
So the ultimate success would be the dissolution of our discipline.
Yeah, the 200, exactly. It's a bit like if you're setting up a company, the ultimate success is to have sold the company on to another company.
Wow, what a lovely message, Chris. You know, it's we better close the podcast at the moment. What an absolute joy and a pleasure to talk to you. I always learn from you, and this was no exception. And I know I'm speaking on behalf of many people who are listening in wanting to congratulate you once again on your really thoroughly well-deserved recognition and receipt of the Carol Nachman Prize. But also thank you for all of the incredible knowledge you've shared with us all, and at a personal level, the friendship and empowerment that you brought, because working together is a whole lot more fun than working apart. And thanks also to all of you who have listened into the podcast. I hope you've enjoyed this discussion and gained some insights into how rheumatology research is progressing, but also how a great rheumatologist can make such a difference. And please subscribe to the CSF in your favorite podcast app. Visit the CSF site to download the latest paper slide summaries, author interviews, and monthly podcasts. It's an incredible resource. It's there. We hope you'll use it. We hope it will ultimately improve the way in which you look after patients, which is ultimately why we're all here. So thanks ever so much for your attention. Thanks, Chris. And I hope you find the podcast useful. Stay safe, stay healthy. Bye-bye.